Hernia, external abdominal hernias. Definition: protrusion of a viscus or a part of a viscus, usually within a peritoneal sac, through a defect in the abdominal wall. Etiology: congenital and acquired. Congenital or preformed sac, unobliterated processus vaginalis leading to congenital inguinal hernia. Unobliterated physiological umbilical hernia leads to congenital umbilical hernia or omphalocele. Acquired cause: raised intra-abdominal pressure or weak abdominal wall. Raised intra-abdominal pressure due to chronic cough, heavy work, obesity, straining at micturition or stools, abdominal swelling, splenomegaly, or pregnant uterus. Weak abdominal wall due to debility, senility, obesity, pregnancy, weak scar, damaged nerve supply of the muscles. Clinical definition of hernia: painless swelling characterized by being reducible or giving history of reducibility, expansile impulse on cuff, on anatomical site, and with defect. Components of hernia: sac, content, and covering. Neck is wide except in femoral and paraumbilical hernias, well defined except in incisional and direct hernias. Reduction of a hernia means reduction of its contents into the peritoneal cavity, while the sac remains empty in place. Components: sac, a peritoneal pouch which bulges through the abdominal wall defect. It has a neck, body, and fundus. Coverings: structures which are stretched over the sac. Contents: any abdominal viscus except for the pancreas because it's retroperitoneal. Usually intestine, such as enterocele or omentocele or both. Types of hernia: Richter's hernia, Letter's hernia, Madel's or W hernia, urinary bladder. Richter's hernia, common in femoral hernia. The content is part of bowel circumference. Lumen is patent. Letter's hernia, the content is Meckel's diverticulum. Madel's hernia, the content is 2 loops of intestine with intermediate loop in the peritoneal cavity. Urinary bladder, part of the bladder may protrude into inguinal or femoral hernia, usually protruding along the inner side of the sac, lying outside it forming sliding hernia. Diagnosis: these questions help diagnosis of clinically suspected hernia. Is the swelling a hernia? The hernia is characterized by presenting at anatomical site of hernia, giving expansile impulse on cuff except if it's strangulated, reducible except if it's irreducible, obstructed or strangulated. By transillumination it's opaque except in children. Which type? Depending on the site, special features, and tests. What are contents? Usually intestine or omentum. And we have to compare between the intestine or omentum. The intestine, enterocele, soft in consistency. Gurgling occurs during reduction. Reduction is difficult at first, then it becomes easy. Percussion is resonant, and X-ray shows gases. For the omentum or omentocele, it's doughy in consistency, gurgling is absent, and it's easy to be reduced at first, then it becomes difficult. Percussion, it's dull, and there are no gases in the X-ray. Is it complicated? We're gonna talk about this later. If there are any cause for raised intra-abdominal pressure or weak abdominal wall, it must be treated before surgery. History and examination of chest, abdomen, urinary bladder, and anus. And then we have weak abdominal muscles. They present by multiplicity of hernias, divercation of recti, bulge of lower abdomen on straining, and this is called Malgigny bulge. Is there any other hernia? Is the patient fit for surgery? Examine for cardiac or respiratory problems, hypertension, and diabetes. Complications of hernia are those of the content. Most serious complication is strangulation that needs urgent surgery. Truss is better avoided because it may precipitate strangulation, but may be used in ill, unfit patients with reducible hernia. Polypropylene, no tension repair by mesh hernioplasty, is a popular nowadays and has lowest incidence of recurrence. Complications are divided into irreducibility, obstruction, strangulation, inflammation, hydrocele of hernial sac, and torsion of omentum, and we're going to discuss it later after treatment. Treatment: for uncomplicated cases, treatment of predisposing factors first, then surgery is advised to avoid complications. In complicated cases, treatment of complications, treatment of hernia, then treatment of predisposing factors. There are 3 main types of hernia operations: herniotomy or herniectomy. It means excision of the sac, done alone or as a part of herniorrhaphy or hernioplasty. Herniorrhaphy, it includes herniotomy and repairing the defect by approximation of local tissues. Hernioplasty includes herniotomy and closure of the defect without tension using imported material, which may be natural as fascia lata or synthetic mesh such as polypropylene. Complications: irreducibility. Definition: failure to return the contents into the abdomen. Causes: adhesions between contents and the sac, or adhesions between the contents themselves, or protrusion of more omentum within the sac. Obstruction: it occurs in irreducible hernias due to occlusion of the intestinal lumen from inside by fecolith or from outside by bands of adhesion. In a purely obstructed hernia, the blood supply is unaffected. Symptoms of intestinal obstruction: vomiting, distension, colics, and absolute constipation. Signs: the hernia becomes distended, irreducible, but still soft. Inflammation: this is uncommon complication. Causes: rough taxis, ill-fitting truss, spontaneous inflammation of contents such as appendix, fallopian tube, or ovary. Clinical picture: the hernia is tender but not tense. The overlying skin is red and edematous. Treatment: operation is essential as strangulation cannot be excluded. Hydrocele of the hernia sac: it occurs in narrow-necked sacs if the contents return to abdomen. The neck becomes occluded by omentum. Serous fluid collects in the sac. Clinical picture: cystic swelling in the upper part of the spermatic cord. Treatment: excision. Strangulated hernia: this is the most serious complication. Definition: constriction of contents leading to interruption of their blood supply. If not relieved, gangrene occurs within few hours, from 4 to 6 hours. Incidence: according to the type of hernia, about 2 to 4% in inguinal, 25 to 30% in femoral, 15 to 20% in paraumbilical, and from 3 to 5% in incisional hernias. Strangulation can occur at any age and is commoner after prolonged use of a truss. Causes: extrusion of new contents following straining, repeated attempts at reduction to produce edema. Irreducibility predisposes to obstruction and strangulation, and so operation is essential. Irreducibility without other symptoms of obstruction is almost diagnostic of omentocele. Distinction between obstruction and strangulation in hernias may be difficult. It is safer to treat it as strangulation, and early surgery should be performed. Although the incidence of strangulation is higher in femoral hernias, yet strangulated inguinal hernias account for more than 50% of all strangulated external hernias, as the incidence of inguinal hernia is more. The constricting agent may be resistant structure outside the sac as a superficial or deep inguinal ring, or the gambrinus ligament, the neck of the sac, or bands of adhesions within the sac. Consequences: if the contents are intestine proximal to the strangulated loop, intestine is obstructed with progressive distension and hyperperistalsis. If it's distal to the strangulated loop, intestine is collapsed. The strangulated loop will suffer from obstruction of venous return and arterial obstruction. Obstruction of venous return leads to congestion, leads to accumulation of fluids, increased congestion, then hemorrhage in the wall of intestine into lumen and from surface into the sac. Arterial obstruction leads to devitalization of intestine with extrusion of contents such as fluid, blood, and bacteria into the sac, leading to dark toxic fluid, followed by gangrene. Clinical picture: severe pain at the site of hernia if the hernia contain intestine, symptoms and signs of intestinal obstruction. Locally, the hernia is tense, tender, irreducible, and doesn't show expansile impulse on cuff. In late cases, the skin overlying the hernia is red, edematous, and warm. Gangrene starts at the ring of constriction, then it affects the antimesenteric border, convexity of the loop, and perforation may occur. Later, gangrene affects the whole loop and its mesentery. When infection spreads from the sac to the peritoneum, peritonitis occur. Neglected cases die from septic shock and dehydration. Strangulated hernia may not be accompanied by intestinal obstruction if the hernia contains omentum or if it's a Richter's hernia. Treatment: urgent surgery. Preoperative preparation: nasogastric tube suction, IV infusion of lactated Ringer's solution to correct hypovolemia, IV broad-spectrum antibiotics to guard against septic shock. Steps of the operation: the incision should be planned to expose the fundus of the sac. The fundus of the sac is opened at first to evacuate the toxic fluid, which is full of organisms. The constricting ring should be divided. A groove director or the left finger is inserted inside this ring, and its coverings are divided from outside until the constriction is relieved. The contents are pulled out and examined. To differentiate between the viable and non-viable intestine at operation, we need to know that viable intestine shows normal luster, pink color, pulsating mesenteric arteries, bleeding if injured, they are firm and contract if inched. While the non-viable intestine, they are lustreless, gray or black, non-pulsating, they don't bleed, flabby and thin, and there is no response if they are inched. Dealing with the contents, the omentum is always excised, viable intestine is returned to the abdomen, gangrenous small intestine needs resection and primary anastomosis, gangrenous colon is treated by resection of the gangrenous segment and colostomy. If the intestine looks suspicious, warm packs are applied and the patient is given pure oxygen for a few minutes. Decision is then taken whether the intestine is viable or gangrenous. Repair of the hernia defect using polypropylene sutures, as this suture material is inert and doesn't cause inflammation. Subcutaneous drains are usually needed. Herniotomy, herniorrhaphy, but not hernioplasty. Never put mesh in potentially infected field because pus occurs. Sliding hernia, definition, hernia where a viscus forms a part of the wall of the sac. The commonest are the bladder, cecum, and sigmoid colon. Clinical picture, type of the patient, long-standing hernia in an obese elderly man. The hernia is usually complete oblique inguinal hernia. The hernia is partially reducible. After reduction of the contents, there is still fullness at the site of the hernia. There are urinary symptoms in cases of sliding bladder. Pressing the hernia causes desire to void, double micturition, and reduction of hernia size after micturition. Don't try to dissect the sliding viscus from a sac, as this may lead to devascularization or injury of the viscus. Treatment: free the sliding sac and viscus well from the surrounding structures, then push them back behind the transversalis fascia, which is then repaired. Then perform a strong repair to the inguinal canal using a mesh if required. Anatomy of the inguinal canal. Definition: the inguinal canal is a narrow channel about 4 cm in length at the lower part of the anterior abdominal wall. The anatomical background of the canal is to allow the passage of testis and the spermatic cord to the scrotum. It begins at the deep inguinal ring. This is an opening in the transversalis fascia, ½ inch above the mid-inguinal point, midway between the symphysis pubis and the anterior superior iliac spine. The inferior epigastric vessels run medial to it. The deep inguinal ring is covered anteriorly by the lower border of the internal oblique muscle. It ends as a superficial inguinal ring. There is triangular opening in the external oblique aponeurosis, which is situated ½ inch above and medial to the pubic tubercle. It's bounded by pubic crest below and the medial and lateral crura, which are joined by intercrural fibers. Normally it doesn't admit the tip of the little finger. It's an exit for the spermatic cord and the ilioinguinal nerve. It's backed by conjoined tendon. Directions: medialwards with slight inclination downwards and forwards. Inguinal hernias lie above the inguinal ligaments and above medial to the pubic tubercle, while the femoral hernias lie below the inguinal ligament and below lateral to the pubic tubercle. Walls: the anterior wall, the aponeurosis of the external oblique through the entire extent of the canal, the lowest fleshy fibers of the internal oblique in the lateral half of the canal, the posterior wall, the transversalis fascia in the entire length of the canal and conjoined tendon in front of the fascia in the medial half, the floor, upper grooved surface of the inguinal ligament, medially, the lacunar ligament forming a part of the floor, the roof, the lower border of the internal oblique and the transversus abdominis muscles, arching fibers, protective mechanisms to avoid development of an inguinal hernia. Number 1, obliquity of the inguinal canal. 2, transversalis fascia, although it's thin, but it's a strong layer which supports the posterior wall. Number 3, weak parts of the canal. They are supported by strong structures. The deep inguinal ring is reinforced by condensation of the transversalis fascia and by the fleshy fibers of the lower part of internal oblique in front of it. The superficial inguinal ring is supported by the conjoined tendon posteriorly. Number 4, shutter mechanism. During contraction of the abdominal muscles, the lower border of the conjoined tendon straightens and descends downwards toward the inguinal ligament, so it closes the posterior wall. Number 5, valvular mechanism. Contraction of the external oblique muscle tightens its aponeurosis and narrows the superficial inguinal ring. 6, cremasteric mechanism. Contraction of the cremasteric muscle plugs the superficial inguinal ring and causes bulging of the spermatic cord in the middle third of the inguinal canal, leading to its obliteration. 7, contraction of the transversus abdominal muscle. It pulls and tenses the edges of the internal ring. Transversalis fascia is a thin but strong facial layer which lies in front of the peritoneum. It's the most important defense mechanism against hernia formation. The lower part of the fascia transversalis is thickened, forming the iliopubic tract, which runs just above and parallel to the inguinal ligament. The upper part of the fascia transversalis is also thickened, forming the arch of the transversus abdominis, which lies at the lower border of the transversus muscle. Oblique or indirect inguinal hernia. Etiology: congenital or acquired. Congenital, due to presence of an unobliterated processus vaginalis. Acquired, due to raised intra-abdominal pressure and weak abdominal wall. Pathology: defect, sac, contents, and coverings. Defect: the stretched deep ring lateral to inferior epigastric artery. Sac, congenital or acquired. It lies inside the cord coverings, being anterolateral to the vas and vessels. Contents: usually small intestine, omentum, or both. Coverings: in the inguinal region, skin, superficial fascia, campers and scarpus, external oblique aponeurosis, cremasteric muscle and fascia, and finally internal spermatic fascia. In the scrotum, skin, dartos muscle, external spermatic fascia, cremasteric muscle and fascia, and internal spermatic fascia. Anatomical types: congenital, infantile, and adult. Congenital type: it's due to persistence of the whole processus vaginalis. The hernia reached down to the bottom of the scrotum, scrotal or complete hernia. The testes lying among the contents of the sac, and the testes lie within the lower part of the hernia. Although it's called congenital, but it may appear in adult life. Infantile type: operative finding: the tunica vaginalis extends upwards to the external ring so that the sac passes down behind it. At operation, the tunica is liable to be opened in mistake for the true sac, which will be found behind it, so we have two sacs. Adult type: divided into bibonocele, funicular hernia, and complete or scrotal hernia. Bibonocele, inguinal swelling. The hernia is limited to the inguinal canal and seen as a bulge or swelling in the groin. The processus vaginalis is obliterated at the superficial inguinal ring. Funicular type: the hernia reaches down to the neck of the scrotum. The processus vaginalis is closed only at its lower end, just above the epididymis. The tunica vaginalis is normal, and the sac represents the proximal part of processus vaginalis only. The testis can be felt separate from the hernia and below it. Complete scrotal hernia or inguinal-scrotal swelling. The hernia descends to the bottom of the scrotum. The testis is behind the hernia and difficult to be located. Clinical picture: symptoms: painless inguinal or inguinal-scrotal swelling. Sometimes there is mild groin pain in early stages. The presence of severe acute pain indicates complication. Signs: inguinal or inguinal-scrotal swelling with a narrow neck and white fundus. Swelling shows expansile impulse on cuff and is reducible. Descent of contents is downwards, forwards, and medially. Reduction is obliquely upwards, laterally, and backwards. Internal ring test to differentiate oblique and direct hernia. Internal ring test is not needed if the hernia is scrotal because it's sure to be oblique. Technique: the patient lies down, flexes the knees to relax the abdominal muscles. The hernia is reduced. The deep ring is pressed by the thumb, and the patient stands up and cuffs. Oblique hernia doesn't come out except after releasing the thumb. Direct hernia comes out despite occluding the internal ring because it comes directly from the posterior wall of the inguinal canal. Treatment by surgery. Preoperative preparation. Treat any cause of increased intra-abdominal pressure such as ascites, obesity, difficulty in micturition, bronchitis, abdominal swellings. Types of surgery: herniotomy, herniorrhaphy, and hernioplasty. Herniotomy, performed in cases of hernias in infants and children, opening the fundus of the sac, reduction of the contents, transfixation of the proper neck, excision of the sac. Operation can be performed through external ring without the need to open the inguinal canal. Recurrence is rare due to failure to ligate the sac at the proper neck. If strangulation is neglected, testicular atrophy occurs. Operation is necessary because of the risk of strangulation. A truss is indicated only if there is a contraindication to surgery. Herniorrhaphy, indicated for hernias of adults. Idea: to strengthen posterior wall of the inguinal canal. Herniotomy done first, then repair the hernia defect, performed by non-absorbable suture materials such as polypropylene or Prolene. Plication of the fascia transversalis and reconstruction of internal ring with lateral displacement of the cord. It shouldn't be under tension. Types of herniorrhaphy: Bassini's repair, Schuldeis repair, and McVeigh's repair. Schuldeis and McVeigh, they are not common now. Bassini's repair, inguinal ligament is sutured to the aponeurotic part of the conjoined tendon behind the spermatic cord. Hernioplasty, obliteration of the hernia defect using tissues not from the vicinity of the hernia, not associated with tissue tension. It has the lowest recurrence rate. Indications: the defect is wide or musculoaponeurotic boundaries are too weak to hold sutures. Types: onlay mesh hernioplasty and periperitoneal hernioplasty. Onlay mesh hernioplasty, after excision of the sac, a mesh is placed behind the spermatic cord and fixed to transversus abdominis and its aponeurotic arch superiorly, with iliopubic tract and inguinal ligament inferiorly. The mesh will be impregnated with a dense sheet of fibrous tissue. This operation is called Liechtenstein tension-free mesh repair. Pre-peritoneal hernioplasty, the mesh is placed between the peritoneum and the fascia transversalis, and it can be done by open surgery or laparoscopy. Direct inguinal hernia incidence. Common in elderly males, it may arise in young following appendectomy due to injury of the ilioinguinal nerve causing paralysis of the conjoined tendon. Etiology: defect in conjoined tendon, weakness of the lower abdominal muscles with chronic cough or straining due to urinary problems. Defect: Hasselbalch's triangle, which is bounded by medially lateral border of the rectus muscle, laterally by the inferior epigastric vessels, inferiorly by the medial half of the inguinal ligament. Clinical picture: type of the patient, old males. Symptoms: painless, reducible swelling. Bilaterality is common and it's called Malgagny bulge. Signs: inguinal swelling, descend forwards, reducible, backwards, internal ring negative, and gives expansile impulse on cuff. Complications: they are very unusual. In practice, females never develop direct hernia. Herniotomy is not usually needed as the sac is small and composed of mainly extraperitoneal fat. A truss may be indicated if the patient is not fit for surgery. Treatment: essentially surgical, removal of the cause of straining. Prostatectomy should precede hernia repair in elderly male with senile enlargement of the prostate. Operation: repair of the weak posterior wall of the inguinal canal by plication of the fascia transversalis, and mesh hernioplasty is indicated. How to differentiate between oblique and direct inguinal hernia. For age: oblique, any age; direct, elderly. Side: uni or bilateral in oblique, while in direct hernia it's commonly bilateral. Shape: oblong in oblique hernia, while it's hemispherical in direct. Descent: for oblique hernia, downwards, forwards, and medially. For the reduction, upwards, backwards, and laterally. For the direct hernia, descent is forwards and reduction is backwards. Oblique hernia: descent to scrotum may occur, the size may reach large size, and complications are liable to occur. With positive internal ring test, the hernia doesn't protrude. For the direct hernia, it's very rare to descend to the scrotum, size usually small, complications are rare, and for the internal ring test it's negative, the hernia protrudes. Relation of the neck of the sac to the inferior epigastric artery, intraoperative. For the oblique hernia, it's lateral to the artery, while in direct hernia, it's medial to the artery. Anatomy of the femoral canal. Femoral sheath: it surrounds the upper 4 cm of femoral vessels in the upper part of the femoral triangle. Compartments: lateral, middle, and medial. Lateral compartment: femoral artery and femoral branch of the genitofemoral nerve. Medial compartment is the femoral canal, fat, and lymph node of Cloquet. Middle compartment: femoral vein. Femoral canal: the most medial compartment of the femoral sheath, about ½ inch long. The femoral canal is cone-shaped, mouth or femoral ring, open upwards behind the inguinal ligament, apex below and formed by fusion of the medial border of femoral sheath and the septum between the femoral canal and the femoral vein. Apex of the canal is closed because the saphenous opening is found on the interior wall of the femoral sheath. Relations of the femoral ring are: anteriorly, inguinal ligament or Poupart's ligament; posteriorly, pectineal fascia and pectineal ligament, Cooper's ligament; laterally, femoral vein; medially, lacunar or Gambrinus ligament. Contents: fat, lymphatics, and 1 lymph node of Cloquet. Functions: to give a space for expansion of the femoral vein. Femoral hernia. Components: sac, contents and coverings. Sac: the sac of a femoral hernia proceeds downwards in the femoral canal, then forwards, stretching the cribriform fascia, then upwards and laterally towards inguinal ligament. The neck of the sac is narrow. Complications are common, irreducibility and strangulation. Contents, usually omentum, bowel or orny part of the circumference of the bowel, Richter's hernia. Coverings, skin, superficial fascia, cribriform fascia, transversalis fascia from anterior wall of the canal, and finally stretched femoral septum. The clinical picture, type of the patient, more common in females, especially after repeated pregnancies. Symptoms, rounded painless swelling unless it's complicated. Signs, rounded swelling with anatomical site below the medial part of the inguinal ligament and below and lateral to the pubic tubercle, giving expansile impulse on cuff. Direction of reduction is downwards, then backwards, and finally upwards. Pressure on the saphenous opening obliterates the impulse and preventing the descent of the hernia. Negative internal inguinal ring test and may present for the first time with strangulation in 40% of cases. Differential diagnosis, swelling in femoral triangle, reducible such as inguinal hernia, saphenopharynx, aneurysm of the femoral artery and psoas abscess, irreducible inguinal hernia, lipoma, inguinal lymphadenopathy, and iliopsoas bursa. Abnormal obturator artery may be present, which represents enlarged pubic branch of the inferior epigastric artery when obturator artery is congenitally absent in 30% of cases. In 10% of cases, it's present in dangerous site behind lacunar ligament, as we might cut the lacunar ligament during repair of hernia. In 20% of cases, it's present in safe site behind the symphysis pubis or lateral to the ring. A truss is contraindicated because the possibility of strangulation is higher than inguinal hernia. Treatment, surgery is the only line of treatment. The idea to close the femoral ring, whether by direct sutures or placement of a mesh. Direct sutures by suturing pectineal ligament with inguinal ligament. Placement of a mesh, the operation can be done by open surgery or laparoscopy. Types of approaches, McVitie's operation, the preferable high approach or low approach, Lockwood's or inguinal approach. During repair of femoral hernia, the surgeon should be aware of the femoral vein on the lateral side, urinary bladder on the medial side, and to avoid injury of the abdominal obturator artery, which is present in 30% of cases, as we may cut lacunar ligament during repair. Femoral hernia is the most liable for strangulation because the neck of the sac is narrow, the constricting agent, which is the crescentic edge of Gambernat's ligament, is sharp. If occurred, it presents with acute painful groin swelling. The hernia is tense, tender, irreducible with no impulse on cuff, plus or minus features of intestinal obstruction. Intestinal obstruction is absent if the content of the sac is omentum, Meckel's diverticulum or Letter's hernia, and finally, part of the circumference of the bowel such as Richter's hernia, and this concludes part 1 of hernia.